right, now we're going to talk about drugs that we use to treat disorders of the nervous system. And, some of them are the more common stuff like depression, very common medication used in the population. And then some of the more, not obscure, but less common things that you'll see more likely in the hospital setting. But that's the topic, nervous system pharmacology. So in order to understand nervous system pharmacology, we have to take a few minutes to review the neuron and neuronal transmission, because almost all pharmacology in this body system impacts that in some way. So let's see what your slide says. An understanding of the neuron, neuronal discharge, and neurotransmitters is the basis of understanding nervous system pharmacology. Neurotransmitters are the mechanism by which an impulse travels through the brain and out into the periphery, eliciting a response. And it's also the mechanism by which stimulus from the periphery is conducted back to the brain. I mean, the way that nerve cells or neurons communicate with each other, whether it's the central nervous system or the peripheral nervous system, is by way of neurotransmitters. So neurotransmitters is really the topic of conversation, and how they are produced, released, carry their message, and then degraded, because pharmacology, one way or another, is going to impact that somehow. So neurotransmitters are either excitatory or inhibitory. Like a nerve is like a receiver, right? The way a neuron is structured, and I think we'll look at this in a minute, the way a neuron is structured, it receives stimuli from its environment, and that stimuli can be in terms of neurotransmitters, chemical neurotransmitters. It can be electrolytes, it can be temperature, it can be pH, it can be exogenously administered drugs. Lots of things are stimuli. And then those stimuli are conducted to the nucleus, or to the cell body. Not really the nucleus, but the cell body, which is sort of command central of the nerve cell. And then those stimuli are processed. And if that cell is stimulated to the point of excitation, we refer to it as threshold, well then that nerve cell will discharge. It will do whatever it is it's supposed to do, and it will carry the message of discharge forward to the next cell by way of a neurotransmitter. On the other hand, for all the stimuli that the nerve is getting, some of it will be inhibitory or suppressive. And if the information that's processed in the cell body is ultimately suppressive, then that cell will not discharge. It will not carry forward its message to the next cell. So hopefully when we look at the diagram, that'll be a little clearer. But the reason I mention it now is because this slide talks about the neurotransmitters. Some are excitatory and some are inhibitory. In other words, the message they carry to the next nerve cell may either be one of excitation or one of inhibition, and sometimes some of them can serve both functions depending on which part of the brain they're working. So here are some of the common neurotransmitters. Norepinephrine, which is usually excitatory, may be inhibitory. Serotonin, which is excitatory in some places and inhibitory in another. Dopamine, which is almost always inhibitory. Acetylcholine, which is virtually always excitatory. Gamma-aminobutyric acid, also referred to as GABA, which is always inhibitory. In fact, I think that's the most common inhibitory neurotransmitter in the brain. And then glutamate, which I know is the most common excitatory neurotransmitter in the brain. So these are neurotransmitters. These are one of the things that carry messages to the next cell. And the message may be excitatory or inhibitory, as we just discussed. Neurotransmitters really are the key. You will see that so many of the drugs we give, almost all of them, impact the neurotransmitter in some way or another. The body, like the normally healthy, functioning body, always exists in a balance. I know I've said that many times, but the body likes a steady state. The body likes homeostasis, that seesaw on an even keel. So the appropriate balance between excitation and inhibition, in other words, that seesaw on an even keel, results in normal functioning. If you have excesses in inhibitors, it will produce a predictable set of symptoms. Some disease states are characterized by too much inhibition of neurons. Other disease states are characterized by too much excitation. So excesses in either way, either edge of that seesaw flies up, you're going to have a problem. So our job with drug therapy usually is to try to normalize that seesaw again, get things back to a steady state. All right, so here's the neurotransmitter, and let's see. Well, not neuro. Here's the neurons. Let me see if I can figure out how to draw the things I want to draw here. All right, what you're seeing in most of this picture is a single neuron, and I'm going to bracket it on the left side as you look at the screen with a red bracket, an unsteady looking red bracket. This whole thing is one neuron inside the red. So what you see at the very top of the screen are the receivers of the neuron. I'm labeling them as ones. There's ones everywhere. These are dendrites, and dendrites are like the antenna. Everything with a one next to it is a dendrite. And these dendrites are protruding out into the environment, picking up signals. And like I said, that signal might be a neurotransmitter that came from another nerve cell. It might be a certain concentration of electrolytes. It might just be a temperature. Sometimes extremes of temperature, and in the body an extreme of temperature is a couple degrees, is carrying a message. It might be enzymes, just all kinds of things. Anything that, and they bind to receptors. You can't see them here, but these dendrites all have little receptors on them, and whatever that stimulator is, it will bind. And all of these signals, all of these ones, some of them are signals of excitation, and some of them are signals of inhibition. All of those signals are conducted till the cell body, which I am outlining here. I'm circling it actually in red and labeling it with a 2. So that's the cell body. That's command central. All of these signals being perceived by the dendrites that are labeled as number 1 are conducted down to the cell body as labeled as number 2. And the cell body is the nerve center, no pun intended, of the nerve cell. It's where the nucleus is, it's where the organelles are, it's where stuff happens. All of those impulses are processed here. Now remember, some of those impulses received by the dendrites labeled as number 1, some of them are excitatory and some of them are inhibitory. And they'll all be processed here in number 2. If the exciters win, if this cell is stimulated above a certain threshold, if threshold is reached, this cell will excite, it will discharge, it will have an action potential, it will do whatever it's supposed to do. If it's a muscle cell, it'll contract. Like if it's a muscle cell in the gut, it will contract and you'll have a bowel movement. Well, you have to have more than one cell, but you know what I mean. If it's in your brain, it will release its neuron to the next cell. If it's in the peripheral nervous system, it might make your finger move. If it's a sensory neuron, it'll conduct a sensation back to the brain, but whatever this cell does, it will do it if excitation is reached. On the other hand, if all of those stimuli that are received as number 1 and processed in number 2 if most of them are inhibitory, if inhibitory dominates, then this cell will not discharge. It will not do whatever it does that this cell does. If it's a muscle, it won't contract. If it's a brain cell, it won't carry a message forward. And that will be inhibition. And then the cell just continues to receive stimuli, and no doubt sometime soon it will reach threshold and it will excite. But you balance inhibitory and excitatory. I mean, you don't want all your cells to be functioning all the time, obviously. You do need a period of rest. You're sitting here listening to your audio, right, watching your PowerPoint. So you have some cells in contraction, right? You're sitting up. I mean, you're not falling over on the floor. So some of the, like your back muscles are contracted. Your hands are probably doing something, so there's various muscle contraction going on, but your whole body's not contracting. You know, there are certain relaxations going on too. That's the balance between inhibition and excitation. You don't want everything being excited all the time, or you'd be sitting there stiff as a board. You also don't want everything relaxing all the time, or you'd be sprawled out on the floor. So you got to have that balance, excitation and inhibition. Now, when this cell reaches threshold, when it excites, when it's going to discharge an action potential, then what happens is it's about voltage. It reaches a certain voltage. And that voltage is conducted down a specialized area of this neuron, which I am now bracketing and labeling as number 3. and that's the myelin sheath. This thing is called an axon. This whole thing that is number 3 is called an axon, and the axon is insulated with myelin. You see it looks thicker there and bumpy, and that's white matter, and that's myelin, and that allows the impulse to conduct down. You see these little divots here, where I'll just put like a little X so you can see what I'm talking about. You see little bumps in the road. Those are called nodes of Ranvier, and that's where the impulse jumps. It jumps from node to node to node, and then that impulse will continue to move, and I'm going to put another X here, and then a red line with an arrow. The impulse moves all the way to the very end of this neuron, and it's still all one neuron here. You can't really see it on this slide. I'm just putting arrows, but at the very end of the neuron, there's a little thing that looks like a triangle, and that's where neurotransmitter is stored. There's neurotransmitter in those little triangles, and when this cell is excited, it will release neurotransmitter from that triangle, and that neurotransmitter will go on to bind to a receiver on the next neuron. You see a bunch of other little neurons here. We'll label them number 4. These are referred to as postsynaptic neurons, and they're going to receive the neurotransmitter that is released by the main neuron here. So bottom line is, most of this picture is one big neuron, and that's labeled, oh, I'm going to sneeze. Sorry about that. That one big neuron is bracketed in red, and now in blue, I'm writing a big N. This whole thing is one neuron. Oh, it's nice to have toys to play with here. And that neuron has several different anatomical aspects. The numbers 1 are the dendrites that are the receivers. They have receptors and they receive stimuli from all around. All of that stimuli is conducted to the cell body, which is labeled as number 2. And then number 2 is where all those stimuli are processed, inhibitory stimuli and excitatory stimuli. If inhibitory stimuli wins, nothing happens, it's dead right there. If excitatory stimuli wins, then an impulse is conducted down the axon, which is labeled as number 3, and that stimulus jumps down number 3 from node to node, labeled by the little X's, and that stimulus continues all the way to the very terminal end of that neuron, where you see the red squiggly lines with arrows on the end of them. And what's hard to visualize here is that there's little triangles there that contain neurotransmitter. That neurotransmitter will be released and bind to receivers on the postsynaptic neuron dendrites, which are labeled as number 4. That process is what we need to manage when we're giving drug therapy. Okay, neurotransmitter synthesis, release, and removal. That is really the target of where drugs work. So neurotransmitters are stored in those little triangle things at the end of the nerve. Neurotransmitters, dopamine, norepinephrine, serotonin, GABA, etc. And the neurotransmitter has to be synthesized, and then it's stored in vesicles there. It's released when that neuron reaches excitation. It's released out into the environment with the purpose of binding to a postsynaptic receptor. Now, if it doesn't bind to a postsynaptic receptor very fast, it has to be cleared from the site. It will either be reuptaken, actively pumped back in to the presynaptic terminal, or there might be enzymes around that break it down and metabolize it, or it might just diffuse away. And that's actually probably what the next few slides say. Okay, here we go. So this is up close and terminal. Up close and terminal, up close and personal. Good grief. All right. So what I'm outlining now, what I'm circling now in red, is the synapse. This is blown up from the last neuron we saw. So what's labeled as number 1 now is that very end of that neuron. Remember I had the red lines with arrows at the end of it, and I said it's a little triangle and you can't see it, but there's neurotransmitter? That's what we're looking at now. Number 1 is that little triangle, and inside, labeled number 2, it looks like soccer balls, that is the neurotransmitter. In this case, I'm using the example of acetylcholine because it's just such an easy example to use. When this neuron is excited, right? When excitation wins and the impulse comes down the axon, this neuron will release neurotransmitter into the extracellular space, which is labeled as number 3. This is referred to as the synaptic cleft. The synaptic cleft is the area outside of one neuron, well, outside of both of them really, where the neurotransmitter diffuses trying to bind. And when you look at number 4, that's what you see. All those little speckles are that neurotransmitter having been released from number 2 are now trying to bind to receptors. And the receptors, I'm going to circle them in blue. Here's a receptor. Here's a receptor. And the neurotransmitter one. Now, this neurotransmitter, it might be either excitatory or inhibitory, and it's carrying a message to the next neuron. And that next neuron this is a dendrite from the next neuron, which I'm labeling as number 5. And this is just how messages are communicated from one neuron to the other. Neurotransmitter, it's the stuff that's released from one, binds to another, and carries a message. The amount of neurotransmitter available for binding is often at the root of a nervous system disorder. Shortly after its release from the presynaptic terminal, the neurotransmitter is either reuptaken or metabolized, or your slide doesn't say it, but or diffuses away. That neurotransmitter either has to do its job right away or it's going to disappear. And there are 3 mechanisms of disappearing: getting reuptaken by the presynaptic terminal again, or being enzymatically degraded, or just diffusing away from the synapse. Many pharmacologic agents mimic neurotransmitters, block their action, or prolong their destruction or reuptake. So think about what they're doing here. If a drug mimics a neurotransmitter, it's acting like it. It will be referred to as a mimetic, and it's acting like the transmitter doing the job of the neurotransmitter. That would imply the disease state is a consequence of not having enough neurotransmitter, and we're trying to give it more. Some drugs block the action of a neurotransmitter, and that would imply that the disease state is a consequence of too much neurotransmitter action. And then other medications either prolong the destruction of the neurotransmitter or prolong its reuptake by the presynaptic terminal. And that would also imply that the disease is a consequence of not having enough neurotransmitter, and now drug therapy is being used to prolong its destruction or prolong its reuptake and leave more of it at the synapse for a while. Some neurotransmitters are reuptaken in an unchanged form. So if we prolong reuptake, we just leave more neurotransmitter at the synapse and allow it to do its job. Other neurotransmitters are enzymatically degraded, and acetylcholine is a good example of this. Acetylcholine is a neurotransmitter that's released from the terminal, right, released from the triangle, diffuses out into the synaptic cleft, and if it doesn't bind to the postsynaptic receptor right away, it's going to be immediately broken down by the enzyme acetylcholinesterase. So we actually have medications that are acetylcholinesterase inhibitors, which inhibit the destruction of the neurotransmitter and prolong its availability. So that's the principle that I want you to keep in mind, so that when we talk about this drug blocks reuptake, this is a blah, blah, blah inhibitor, this is a mimetic, you know what we're talking about. So if that makes sense, that's awesome. If it doesn't, go back and listen to those first few slides again. Now let's look at some diseases and drugs. Okay, first one is depression. I mean, the number of antidepressant prescriptions written in the population, I don't know how many millions it is every day, but undoubtedly, whether you work inpatient, outpatient, or wherever else, if you have anything to do with managing patients' medications, you most certainly come across people who are on antidepressants probably most days of the week. So the problem with depression, the theory of depression, I mean, it's a little more complicated than this, but sort of narrowing it down to the place that we're interested in, depression results from diminished activity of 2 primary neurotransmitters, norepinephrine and serotonin. Now, how you wind up with diminished activity, that's a big topic of conversation, and you could spend a lot of time reading about the pathophysiology of depression. But in the final analysis, there are two neurotransmitters, and there's not enough of them in the functional areas of the brain where mood is determined. Norepinephrine is the primary neurotransmitter in the locus ceruleus. Serotonin is the primary neurotransmitter of another area called the raphe nucleus, and there's not enough of one or both of these being active in those functional areas in the patients. Another one that's really getting a lot of attention more recently is glutamate, and probably some years down the line you'll hear more information about glutamate being really implicit in depression. But right now, norepinephrine and serotonin are the two that we have medication therapy for, and virtually every drug that improves mood, one way or another, increases the amount of these neurotransmitters in these areas of the brain. Now, norepinephrine affects mood also in the cerebral cortex. Norepinephrine, when there's a deficiency of norepinephrine, the patient usually is more seriously depressed. I don't know if that's the way I want to say it, but the depression is usually like deeper, affects like the day-to-day of their lives. Serotonin is more the neurotransmitter that impacts the limbic system, and this is more about like emotion, and like if somebody is depressed because they're having a maladaptive coping response to a major loss like a breakup or a big financial setback or something like that, that's usually more about serotonin. So I don't mean to imply that serotonin-mediated depression isn't a serious problem. It is. But norepinephrine-mediated depression reportedly is like a more deeper depression, the kind of depression where people genuinely like won't get out of bed in the morning, like won't attend to hygiene, stuff like that. But there are two different neurotransmitters, and antidepressants affect both of them. So this shows you the functional area. On the left of the screen as you look at it, let me get my little red pen here. On the left of the screen, this is the bigger version. So, you can see you're coming up the spinal cord here, right? And then you come into the medulla and pons of the brain, and that's what's circled here. I'll recircle it in red. And then up to the thalamus and the cerebral cortex, the cerebrum and the cerebral cortex. But this area, the pons, that's circled in red and then arrowed over and blown up. And in that area of the pons, you can see the locus ceruleus and the raphe nucleus, and those are the mood centers of the brain, and that's where the pathophysiology of depression is believed to occur. So in patients that are depressed, there's not enough of these neurotransmitters in these functional areas of the brain. Drug therapy to manage depression improves the amount of neurotransmitters available in these functional areas. Now remember, we're just not that good with pharmacology. Like we as a healthcare profession, they can't make a drug that just impacts neurotransmitters right here. So almost always when you take a drug that increases neurotransmitter concentration here, it's going to inadvertently increase neurotransmitter concentration somewhere else, and that's why patients are going to have adverse effects. Now you might remember, I think it was just last week that we were talking about GI, and I said serotonin was the primary neurotransmitter of the enteric nervous system in the gut, and it's the one that drives the gut, one of the two. When you take SSRIs, you'll see that one of the side effect profiles is GI symptoms, right? Like nausea, increased bowel motility, perhaps diarrhea, anorexia, loss of appetite, because we're giving drugs that increase serotonin activity in this part of the brain, but it's invariably going to increase serotonin activity elsewhere too. So let's see, pharmacologic management of depression. Selective serotonin reuptake inhibitors. These are the most widely prescribed antidepressant medications in the country. You will see these probably more than anything else. And what they do is block the reuptake of serotonin by the presynaptic terminal. So in those neurons of the raphe nucleus, when those neurons are excited and an impulse comes down the axon, it will cause serotonin to be released by the nerve terminal, by that triangle. And then serotonin will be released, it will bind to neurotransmitters on the next, or it'll bind to receptors on the next neuron, and then it will be reuptaken by that presynaptic terminal. These drugs block that reuptake so that there is more serotonin available for longer. You're increasing the concentration. And these SSRIs really are most effective for emotional depression. Again, the kind of person who they meet criteria for depression, but it is often due to some like recent thing in their life, a bad breakup, losing a job that's so important to them, a major financial setback. I mean, when any of us, if something like that happens, there is going to be a period of disruption and grieving in your life, and then you cope with it and you move on. But some people don't cope appropriately. They have maladaptive coping, and then they will meet criteria for major depressive disorder and can benefit from these medications. I only make that distinction because we don't want everybody who has a bad day to be put on an SSRI. We want people who have criteria for major depressive disorder to be put on an SSRI. All right, so what about SSRIs here? The primary advantage is the lack of cardiovascular effect. Now, without going off into a long history of antidepressants, I will tell you that these, in the scheme of things, these are newer. These were first released in the 1980s, and they were synthesized to be safe. The older antidepressants, like the tricyclic antidepressants that we'll talk about in a little bit, they are extremely effective, but they're also dangerous. You can commit suicide with them. And there understandably was a lot of concern about giving depressed people like a month's worth of pills that they could kill themselves with. So the SSRIs were purposefully designed to be safe. That's why they are selective for serotonin. All of the other side chains were taken away. They were taken off of them. These drugs are very selective. So their primary advantage, other than treating depression, of course, is lack of cardiovascular effect. There are no anticholinergic side effects. It is really hard to hurt yourself with SSRIs. Generally speaking, you could take a month's worth of SSRIs and have it not be fatal. I'm not suggesting that anybody do it, but you get the idea. It's much safer to give these to a depressed patient. The SSRIs also have been found to be effective for other mood disorders like panic, OCD, bulimia are listed here. Different SSRIs have gotten FDA indications for it, but most of them, you could try pretty much any one of them. In the family of SSRIs, they all have like little nuances that make one a little bit different from the other, but as a class, they are generally effective for things like panic and OCD, usually in higher doses than we use for depression. The SSRIs are not effective for pain management. Almost every other antidepressant is, and that's because the other antidepressants are not selective for serotonin. They have a norepinephrine component, which makes them helpful for pain. These are the SSRIs. I'm sure you've heard of them: Paxil, Zoloft, Celexa, Lexapro, and Prozac. And in terms of side effects, they are primarily related to serotonin. Some of the SSRIs are actually considered CNS activating. They might like pick somebody up a little bit. Others are almost, sedative is kind of a strong word, but they have like depressant properties. The extremes are Prozac and Paxil. Prozac tends to be more activating, so that's like a really good choice for people who are depressed and they just don't want to move. They want to get out of bed, they're not interested in doing anything, you know, they don't look forward to anything, all that kind of stuff. That, you know, you might see them prescribe Prozac. It might give them a little pick-me-up. On the other hand, Paxil tends to be more calming. So people whose depression is more characterized by, you know, anxiety, I lay in bed at night, I worry about stuff, I can't sleep. Those are the kind of people that benefit more from Paxil. Some of them also have the potential to produce akathisia side effects, this inability to sit still, extrapyramidal side effects, twitching and stuff like that, facial movements. It's not common, but it does happen, and if it happens, you want to notify the resident or the prescriber right away because the drug needs to be tapered off and discontinued. They also sometimes cause tinnitus and headache, especially early in therapy, and sometimes to the point of the patient will stop taking it. This, again, is where patient education really comes into play. You know, lots of people, especially in hospitals, it seems like where rounds happen so fast and everybody's got so much to do, but also in primary care when people are trying to see 25 patients a day, they just prescribe the stuff and don't tell the patient anything about it. Tinnitus and headache are two side effects that will make people stop taking stuff, especially if they don't anticipate it and they don't know it's normal. So if you have a patient who's been put on one of these drugs fairly recently and they're having these side effects, if they mention it to you, do mention that it's normal. Reassure them that they'll get over it. Maybe if they have a PRN for an analgesic like a Motrin or something, you want to give it, because it's true. The headache in the beginning can be very profound, and let the prescriber know. Sometimes the thing to do is to cut the dose in half and just titrate them up more slowly. But it's like, this is exactly the kind of stuff where people just don't know, and it's really uncomfortable, and nobody mentioned it, and it's not normal, and they just stop taking it, and that's that. And then they don't get help for their depression. I've seen that particular one happen on numerous occasions. What else do we have? Oh, the SSRIs are notorious for this sexual side effect profile all along the spectrum: loss of libido, inability to get an erection, inability to ejaculate, inability for women to have an orgasm, all kinds of stuff. It's another one of those patient things that they really need some education on. And also, do reassure patients that if they're having this side effect with these drugs, it's not like everyone is going to do it to them. It's very reasonable that when patients have sexual side effects with one SSRI, they'll get switched to another one and they'll tolerate it really well. So again, another patient education thing, that you don't want them to think that just because one did it, because I mean, let's face it, if it's seriously affecting your sex drive, of course people don't want to take it. And they might be reluctant to take them ever again in the future, because if they think, well, if one did it, they'll all do it, Patient education, I mean, I just can't say enough about it. So many things that people, they stop taking them, they don't do it right, just because they don't know what to expect. Now, remember that GI thing we were talking about? A lot of people who start SSRIs will almost get a little nauseous or just lose their appetite, so much so that it's not unusual to lose weight early in therapy. When these drugs first came out, people thought they were going to be weight loss drugs, but then what we found is after a while, like anything else, your body adapts, and ultimately there's a risk for weight gain. Another thing that you want to make sure your patients know absolutely, and hopefully the prescribers tell them this too, but sometimes they don't. You don't want them to stop taking these abruptly. These drugs definitely cannot, especially if they've been on them for a few weeks, you don't want them to stop it abruptly. There's actually a syndrome here called antidepressant discontinuation syndrome. I think it shows up a little bit later in your slide set. But if they abruptly stop an antidepressant, especially if they've been taking it for a few weeks, they'll have all sorts of problems, including a rebound of depressive symptoms that usually gets worse, but also like even flu-like symptoms. I actually had one patient that had to be hospitalized because she stopped taking an antidepressant suddenly, and she was so sick, had such unbelievable profound headache, she had to be hospitalized for pain management. Really important that if people want to stop taking these drugs, they need to let somebody know so it can be tapered off, or they're going to get sick. All right. I said it's really hard to hurt yourself with an SSRI, and it really is. It's not. It's very unusual to be able to like do any serious damage. There are people who get serotonin syndrome. Serotonin syndrome is what happens to your body when there's too much serotonin on board. So of course, potentially, if you take a whole bottle of SSRIs, that may happen, or it may not. But usually where you see serotonin syndrome is when people are on combinations of more than one serotonergic medication and they have some risk factor for not being able to metabolize it well, like appreciably decreased liver function or something. So these are some examples of serotonergic drugs. Obviously the SSRIs, SNRIs, TCAs and MAO inhibitors we'll talk about in a little bit, but these are all antidepressants which ultimately all increase your serotonin concentration. Also the triptans like sumatriptan, for migraine headache, and there's a bunch of drugs in that category, of course. I can't think of any of them right now, but there's several drugs in the triptan family. They're serotonergic. Tramadol, you'll probably know this as Ultram. That is serotonergic. Meperidine is serotonergic. Dextromethorphan, which is the cough suppressant in most over-the-counter cough and cold medications, that is serotonergic. And linezolid, which is An antibiotic is a serotonin increasing serotonin drug. So when people are on a couple of these and then you throw on an SSRI, yes, then they are at risk of having too much serotonin in their body. And then add in a little liver dysfunction and you really have some potential. And so this is the spectrum of findings in serotonin syndrome. And you can see it goes from mild on the left side of the screen to potentially life-threatening. I've never seen anybody die from this, and I've also, you'll also see people move. They might get some symptoms or go back and forth a little bit. It's not like just one straight shot unipolar direction. But usually you'll see the more mild end of the syndrome here, like tremor, altered mental status. Hyperthermia is not uncommon. Actually, let's look at the next slide too. Yeah, this is another way of saying the same thing. Mydriasis, right, where the pupils dilate, tachycardia. This is just like increased stimulation of the central nervous system. If any of you work in emergency rooms or with the right population, you might recognize this as looking very similar to people who have taken too much ecstasy or MDMA or Molly or whatever you call it in your neck of the woods, because MDMA, which is ecstasy, is just a great big bunch of serotonin. It's a drug that hugely increases serotonin in your brain. The fine line is finding that amount of serotonin which produces euphoria or ecstasy without going too far and making you have a serotonergic crisis. Anybody who does, these are the joys of practicing in Las Vegas. Anybody who has taken ecstasy will tell you that of one of their biggest concerns is not getting the real stuff when they buy it on the street. And so after they take ecstasy, there's a couple of things that you can be sure will happen if you really got true MDMA. One is that within an hour or so of taking it, you will either vomit or have a bowel movement, and the patients describe them as being the best bowel movement you ever had or the best vomit you ever had. But it's massive serotonergic stimulation. Remember what I said about serotonin and the gut. So if you get real MDMA, you're going to either have a great bowel movement or a great vomit because you've had massive serotonergic stimulation of the gut. The other thing they look for in the mirror is mydriasis, is dilated pupils, because they know if they've really got Molly on board, their pupils are going to dilate because it's like serotonin overload. Like I said, the challenge for them is to take enough to be ecstatic without going into serotonergic crisis and being hypertensive and tachycardic and agitated and all that kind of stuff. So obviously when we give, antidepressants, Molly, which is a popular form of on-the-street ecstasy, was originally designed to be an antidepressant, but I guess it was just too good. You can't have people running around in ecstasy all day long. That's not really the role of an antidepressant, right? But that's what serotonin is. In the right bolus, it does produce an ecstatic sort of lifestyle. We tone it down a little bit, return patients to a normal baseline state, and then you've got an effective antidepressant. All right, what else about them? Selective serotonin reuptake inhibitors. Yes, consider cytochrome P450 interactions. You know all about P450 because we talked about it. Again, Prozac and Paxil are the two biggest offenders here. They are inhibitors of the cytochrome P450 2D6 isoenzyme. And some of the other SSRIs do have some potential for interaction. Lexapro is the one that doesn't. Lexapro is the only SSRI that I know of that doesn't have any cytochrome P450 interaction at all. But if you've got patients on Prozac or Paxil and a bunch of other drugs in your free time, which I know you never have when you're at work, but if you have a minute just to cruise those drug interactions, especially if somebody just ordered the Paxil or Prozac, you might do yourself a favor and save the patient some aggravation in the long run. All right, next we got the SNRIs, serotonin norepinephrine reuptake inhibitors. So now you can see it's not selective for serotonin anymore. Now we have drugs that inhibit the reuptake of serotonin and norepinephrine. These drugs have more juice. They're just a little bit stronger. They incorporate that norepinephrine piece. Remember I said the SSRIs were originally designed to be safe, and they are safe. It really is hard to hurt yourself with them, and that's great. Except that what you achieve in safety, you sacrifice in efficacy. So SSRIs, while they are great for people with functional depression or emotional depression, they're just not as effective with people with more serious endogenous type depression. So after the SSRIs were born, then somebody was like, hey, this is great. We have safe drugs for people whose depression is more functional. But what about the really, really sicker, almost psychotic kind of people? What do we do about them? And so some pharmacologists, excuse me, synthesized a drug that now has both the serotonin and norepinephrine reuptake pieces. So you're increasing the concentrations of serotonin and norepinephrine in those functional areas of the brain. Adding back the norepinephrine piece made the drugs more powerful, more efficacious, and it's the norepinephrine that contributes to the control of chronic pain, which you might remember we talked about a few weeks ago. Because the norepinephrine effect is present, SNRIs have greater clinical efficacy, broader spectrum of use, like I just said, and, you guessed it, greater adverse effect potential. The stronger a drug is, the stronger the side effects are. That's always the way it's going to be. So yes, these drugs are more powerful. They are going to be more effective for people whose depression is really, really like life inhibiting. But you also have to be watchful of the side effects. Not nearly as bad as some of the older antidepressants, but mostly it's about cardiovascular effects in higher doses. You need to be watching for hypertension. And then we have a collection of drugs called atypical antidepressants. I didn't go into the whole long thing here because there's a ton of them. I'm sure you know some of the names: Remeron, Trazodone, Deseril. There's just a ton of them that, Wellbutrin. They're atypical because they're not selective for serotonin, or they're not selective for serotonin and norepinephrine. They do affect those things. I mean, at the end of the road, any effective antidepressant is going to be one that increases those neurotransmitters in those functional areas of the brain. But the atypicals also have other actions too. They're not selective. And that's why they are collectively called atypicals. Now, the heterocyclics, those are old-time antidepressants. You probably won't see them used as much for depression anymore, but you do see them used for the management of neuropathic pain, the management of sometimes mood stabilization. So that's why they're worth mentioning here. These are called the heterocyclics. More conventionally, we call them the tricyclics. They also block the reuptake of norepinephrine and serotonin. It's just that they do lots of other things too. These are not selective at all. These were among the very first antidepressants we had. Very effective, probably the most effective antidepressants there are. The downside is they have the most potential for danger. So these are the drugs that somebody started with and said, hey, can't we make these safer? And they teased off all these other side chains here and came up with an SSRI. But the tricyclics in their own right, in addition to blocking the reuptake of norepinephrine and serotonin, they also are muscarinic antagonists, which means they're anticholinergic. These are powerful anticholinergics. Many of them will cause sedation, they'll cause constipation, urinary retention, dry mouth, pupillary dilation, all the anticholinergic side effects we've been talking about all quarter. They're also weak alpha-1 receptor antagonists, which means that they block norepinephrine from binding to alpha receptors in the arteries, and so they block the ability of the arteries to constrict when you change position, which leads to orthostasis. The risk here is orthostasis and orthostatic hypotension. They are weak histamine antagonists, so they're antihistamines as well, so can affect the brain that way. Also, your handout doesn't say it, but they also have significant cardiac effects. Some people consider these drugs actual cardiac antidysrhythmics, so lots of side effects here. Very effective antidepressants. These are probably the best one to improve depression, but they have all these side effects, so we just don't use them as much anymore. However, they are extremely effective for neuropathic pain. They are good sedatives. So like younger people, people that can tolerate some of these side effects, people that don't have underlying cardiovascular disease, they're very appropriate, and now they're very cheap, as compared to some of the other antidepressants. So these are some examples. Tofranil and Sermontal are really old school. Like those drugs are bomb drugs. If you have somebody who's like so depressed, they won't talk, they won't move, they won't get up. Elavil is a good antidepressant, although what you do see it used mostly now for is as a sleeper and for neuropathic pain. And Sinequan is also used more as a sedative, and it's used for like anger management kind of stuff in young people. When I used to work in juvenile detention, we used, and even the adult county jail, we used a lot of Sinequan. But the side effects, it's what does it in. So I don't have to read these to you. I just went through them when I was talking about anticholinergic side effects, orthostasis, etc. Also, they lower the seizure threshold, which means if the patient has any potential or any tendency to a seizure, it's more likely to happen if they're on a heterocyclic. Now, again, I mean, I don't mean to, to scare you over these. Like, if somebody doesn't have any risk for seizure, then I'm sure they're going to be fine. But if they already have seizure disorder, or they've recently had a head injury, or for whatever, like there's a tumor, whatever other reason you think they're at risk for seizure, then yes, these drugs, there is that risk. So if you see somebody who gets started on an SSRI and you think they might be having a seizure, it's definitely worth reporting because these drugs increase the risk of it. Yeah, lots of contraindications, mostly because of, the potential danger of them. Also, in terms of laboratory evaluation, the heterocyclics can change some things. These can suppress blood cell development. They can lower your red blood count, your white blood count, your neutrophils. They can put people at risk for anemias and infection. So, when you're reviewing your labs on your patients, keep your eyes peeled, mostly for changes, for things that are different. Also, these can increase blood sugar. So even if somebody doesn't have diabetes or they're on the fence about diabetes, like they're pre-diabetic, and then they get put on a heterocyclic, before anybody jumps to treating them with insulin or something like that, you just might mention, hey, maybe we should stop the heterocyclic and see what happens to the blood sugar, before we put them on life-changing medication. Here's the antidepressant discontinuation syndrome I was telling you about. So antidepressant discontinuation syndrome, it's got its own name now. This is what happens to people who suddenly stop taking drugs that increase the neurotransmitters in their brain. Because think about it, with all these antidepressants, if you block the reuptake of serotonin and or norepinephrine, you're increasing the amount they have on board in their brain. And their body gets used to having that increased amount. And then if you suddenly stop the drug, you're suddenly stopping the increased neurotransmitters. You're basically putting them in neurotransmitter withdrawal, and it will make them sick. Like I said, I had a patient who had to go in the hospital for it. Most problematic if they've been taking them for more than 6 weeks, but I mean, you will see it happen even if they've only been taking them for a few weeks. Just emphasis in patient teaching is don't stop taking these suddenly. Even if you hate them and you don't want to take them anymore, talk to the person who prescribed it about tapering it down. This is a mnemonic FINISH, F-I-N-I-S-H. These are all the things that can happen to people. Flu-like symptoms, insomnia, nausea, sense of imbalance, a sense of ataxia. And this is really true. It's, really can be disturbing. Sensory disturbances. I've had a lot of people say, because patients are always stopping this on their own when they're not taught appropriately, they feel like they have tunnel vision, like their vision gets all messed up and they can't see in the periphery. And just in general, hyperarousal as their body tries to accommodate. So it's just best to stop taking these slowly and steadily in a taper, and it's an important part of patient education. So I think that's all I have to say about that. Let's see what we got next. Yes, seizure disorder. So the seizure drugs, half the seizure drugs out there, we don't use them for seizure, we use them for other stuff, but they all do basically the same thing. So let's see what your slide says here. Seizure disorder happens because of excessive neuronal discharge throughout all or part of the brain. And that's really true. Think about what seizure activity is. When somebody is having a seizure, and there's all types of seizure activity, there's the classic tonic-clonic seizure, there's absence seizures, there's myoclonic seizures. When somebody's having a seizure, all that's happening is that some normal process is happening. It's just happening in an exaggerated, repetitive fashion. Some part of their brain is firing off inappropriately. They're just inappropriate excitation. Remember how we were talking about excitation and inhibition? Well, in seizure disorder, something has gone wrong and there is too much excitation in either all or part of the brain. For that reason, we know that seizure drugs are virtually always about suppressing excitation or increasing inhibition. Seizures come in two general flavors. There are generalized seizures and partial seizures, and these aren't about what part of the body is seizing. These are about what part of the brain is being stimulated. In generalized seizures, it is bilateral. If the patient had an EEG that recorded the abnormal activity, in a generalized seizure, you would see that the abnormal activity is bilateral. This might be the kind of seizure activity you see when somebody is having seizures because they're profoundly hypoglycemic or hyponatremic, or they have epilepsy where we don't really know the origin. But whatever the cause is, it's generalized and bilateral. There is diffuse bilateral neuronal discharge. Now, this may produce a tonic-clonic seizure, or it may produce just like the inappropriate contraction of an arm or a leg or something. You might look at the patient and want to call it a partial seizure, but it's not about what part of the body is seizing. It's about what part of the brain is discharging. And the only really way to know for sure is to look at an EEG. I mean, not that I can interpret an EEG, but, whoever can will tell you. Partial seizures, excuse me, partial seizures are when one part of the brain is affected. And again, this doesn't necessarily mean what the body's doing. Somebody can have a partial seizure and it looks like generalized symptoms. They might have a loss of consciousness. So partial seizure refers to one part of the brain. This often develops when people have scarring in one part of the brain. Maybe they had a head injury, or they have a tumor, or a little localized bleed, or something is happening in one part of the brain, and the brain is exciting inappropriately. Now, like I said, I am no EEG expert, but what you can see, and I only know it because it's labeled, but what you can see if you look at it here, on the left side of the picture are alpha, beta, theta, and delta waves. And they're, they're normal in some cases. Like theta and delta waves may be abnormal depending on the circumstances. But like alpha waves are the kind of waves that people experience when their brain is just sort of not really engaged. They're just maybe like watching mindless TV or, I don't know, awake but not really focused or not really paying attention. Whereas beta waves are the kind of waves that you will see with purposeful brain activity. Hopefully we all have beta waves going on right now, although if you're daydreaming or your mind's wandering, you might have alpha waves. Theta waves are the waves that you might see when someone is sleeping, and if I remember correctly, they may evidence brain damage in like older people or babies or something like that. I don't know. Theta waves and delta waves, I know, represent sleep or brain damage, like in certain circumstances. Not seizure, but some abnormality. But then if you look at the other side of the screen, the three waves that are demonstrated in grand mal epilepsy or tonic-clonic seizure, petit mal or psychomotor seizures, what you can see right off the bat is that the spikes are higher, which means they're a higher voltage because the up and down, like the higher it is, the more voltage is being generated, and you can see the repetition, like the same thing is happening over and over and over again. So those are what seizures look like. There's too much electricity happening in the brain, and it's happening repetitively. And there's any variety of reasons that this can happen. But we have to think about drugs that we use to manage it. I mean, of course, somebody's always going to try to figure out what's the cause and fix the cause. But from my little place in the world, my interest for you is the drugs. So mechanism of action of drug, it is to stop all of this excitation. Notice that the first bullet point says precise mechanism of action for anti-epileptic medications is unknown, but theories are that they decrease excitability and raise seizure threshold by either inhibiting glutamate, which remember I said is the major excitatory neurotransmitter in the brain, or by potentiating GABA, which is the major inhibitory neurotransmitter in the brain. So you're suppressing excitation or potentiating inhibition. That's what they do, at least that's the theories. So we've got lots of different drugs here. It's not my interest to read the names of drugs to you. You probably recognize some of these. Dilantin, as old as it is still very widely used. Keppra is another one, Zonegran. Phenobarbital, I believe, is the drug of choice for grand mal seizure management in children. For absent seizures or pedant mal seizures that we see more commonly in children, there's Klonopin, Depakote, Zerontin. Couple of things about the seizure drugs to keep in mind from, a nursing monitoring perspective. Carbamazepine, which is marketed as Tegretol, it causes its own metabolism. It is capable of auto-inducing its own metabolism. So the more you take it or the longer you take it, you may actually trigger metabolism of it. So that means that you metabolize it and excrete it, so it means levels go down. Remember, with a lot of these seizure medications, especially the older ones, there's really a pretty narrow therapeutic window, and we have to monitor levels, and there's like always a therapeutic level, like say between 10 and 20 mics in serum. Under 10 mics tends to not be as effective. It's below the minimally effective concentration, and above 20 mics may be toxic, and the patient can get toxicities. So many seizure drugs have a narrow range, and it needs to be monitored. And the thing with carbamazepine is, since it can stimulate its own metabolism, the patient might think they're on, they might be on a stable dose for a long time, and then their levels just start going down and down, and maybe they even have a seizure. It's because they're metabolizing it themselves. Their doses need to be increased. And some people get really frustrated by that. They're like, I've been doing everything right. I'm taking this exactly the way I'm supposed to. It's been fine for a year. Like, why is this happening now? And we can tell them it's that this drug has this ability to stimulate its own metabolism. So it's not a bad thing. It doesn't mean they're any sicker. It just means that we need to give more to achieve a therapeutic serum level. Another point to remember, this is an interesting one. Phenetin or Dilantin has zero order kinetics. Zero order kinetics is how we predict its route of elimination. So being able to predict how fast a drug will get metabolized is important, because seizure drugs can be toxic. Like I said, many of them have narrow therapeutic ranges. Dilantin or phenetin actually is typically ranged between 10 and 20 mics. So that means we have to get a serum level above 10 mics to be confident that it's effective, but we don't want it to go above 20 mics or we'll be concerned that it's toxic. Of course, there's exceptions to every rule. If seizures are suppressed at 7 mics, then we leave them there. If it needs to be 25 mics and to suppress their seizures and they're not toxic, we leave them there. But generally speaking, 10 to 20 is the average. And so when patients are above 20 mics, especially if they start to be symptomatic of toxicity, we want to be able to predict how long it's going to be before they metabolize and excrete this stuff. And the way that this translates to you, like in day-to-day patient care, suppose you have a patient who is admitted in Dilantin toxicity. So they're Dilantin toxic. Say the Dilantin level is 40 mics and their pulse is 38 and they're really tired and they don't feel good. Of course they don't, because their pulse is 38. So the question is, how long is it going to be before they excrete this Dilantin, they're not toxic anymore, and their heart rate goes back up? Well, most times we would look at the half-life principle, because most drugs are eliminated by the half-life principle, which is first-order kinetics. But some medications like Dilantin, and for that matter, like alcohol, ethanol alcohol, the kind that we drink recreationally, when the levels get too high, the drug saturates its route of elimination, and they become eliminated by zero-order kinetics. And it takes longer to get rid of it, and so it affects how you predict it. So let's look at the next slide. So say somebody gets admitted with a Dilantin level of 38, like I said, or I said Dilantin level of 40 and a pulse of 38. So bad combination, right? It's like, God, their Dilantin level is like double the upper limit of normal. How long is it going to take before that's gone? Well, if you knew that the half-life of Dilantin was 22 hours, you would expect that in 22 hours, their level would be half of 40. So in 22 hours, their level will drop by 1/2 and be down to 20. So you'd figure, awesome, in less than a day, this patient is going to have a normal dilantin level again. Except that that's not accurate, because when the dilantin levels get too high, you can no longer assume first order kinetics anymore. Now you know that because this drug in high levels saturates its route of elimination, it will be eliminated by first order kinetics, which is not half-life, it's constant amount per unit time. So that's what this diagram is supposed to be illustrating. Let's see how good it works here. All right, first order kinetics, which is how almost all drugs are eliminated. That would mean that at time 0, it's not labeled here, but I'm going to put it on in red. So from left to right on the graph is time. So you got 0 hours, 2 hours, 4 hours, 6 hours, 8 hours, etc. Then we look at concentration from bottom to top. So at the very bottom, the concentration, I mean, time 0 is when you first take it. When you first take it, your serum concentration is nothing. And then, 20, 40, 60, 80, 100, whatever. So when you first take it, let's say that, almost immediately after you take the drug, or maybe we inject it into the patient intravenously, they have a serum level of 100%. If it's eliminated by first order kinetics, in other words, if the half-life principle applies, then in this case, in 4 hours, you're down to 50%. So this drug's half-life is 4 hours, and I'm drawing a red line to try to illustrate this. I don't draw very straight though. But you see what I say? At time 0, you have 100% on board. 4 hours later, you have 50% on board. So the half-life is 4 hours. So that means that in 4 hours, when their level is 50%, you can predict in 4 more hours that 50 will cut in half, and you'll be down to 25. So look at the 8-hour threshold. At 8 hours, you're down to 25%. And then if you could see it here, at 12 hours, you'd be down to 12.5%. With first order kinetics, whatever the half-life is, the serum level drops by 1/2 in that period of time. In this example of first order kinetics, half-life is 4 hours. So if you could rely on first order kinetics and a patient's dilantin level is 20, you would say, well, in 1 half-life, it's going to be down to half. Zero order kinetics is different. Zero order kinetics means a drug has saturated its route of elimination. It's no longer going to eliminate according to the half-life anymore. Now it's going to eliminate over unit time. So at time 0, you first administer the drug, the patient's got 100% on board. In, let's see, in 2 hours, it looks like, in 2 hours, the patient is now down to 90%. See my red lines? So if in 2 hours they dropped by 10%, in another 2 hours, they'll drop another 10%. So at 2 hours, they're down to 90%. In another 2 hours, they're down to 80%. In another 2 hours, they're down to 70%. Sorry, my lines aren't perfect. In another 2 hours, they're down to 60%, and so forth and so on. So it's not about a half-life principle. It's about over this unit of time, we will drop this much, and it just takes longer. So that patient who, in my example, we have a dilantin level of 40, and I know that the half level of dilantin is 22 hours. If it was going to eliminate according to first order kinetics, in 22 hours, that dilantin level would be down to 20. But it's not. So if this patient is only eliminating X amount per unit time, that's how I have to calculate it going forward. The clinical utility in this is that you can predict more accurately how quickly a patient will metabolize something. I'm sure if any of you have ever had alcohol to drink, you know what I'm talking about. If you just drink very moderately, like 1 drink an hour, you will eliminate it by first order kinetics. And 1 hour after having a drink, 1/2 of it will be in your blood, and you're usually considered safe to drive. So if you have 1 drink and an hour later you feel fine, but if before that hour elapses you have another drink, you might be feeling a little giddy, right? Like 2 drinks in an hour, you might be feeling it. Throw in that third one and you can't believe what has happened to you. It's because by the time you get that third one on board, and for some of you, even the second one, you just can't eliminate it. So you're like just piling alcohol on alcohol and not excreting it. And that's what makes the difference. It changes its route of elimination. So anyway, the primary clinical utility here is you can predict more accurately how something will be eliminated. All right, some other things to remember about seizure medications. There are concerns about substituting generic versions, again, because of the narrow therapeutic range. So remember, generic medications are not identical to brands. They are bioequivalent. And bioequivalent just has certain parameters it has to meet, like, the serum level has to be like 85% of the branded drug. So for most drugs, it doesn't really make much difference because most drugs have much higher therapeutic ranges. But for drugs where the balance between effective and toxic is really narrow, there is some concern about using substitutions. They're not bioequivalent. You just have to monitor levels more closely. Of course, the American Academy of Neurology is against substitution because, they're the American Academy of Neurology. They want everything to be done right. Fair enough. Most experts who are not with the American Academy of Neurology say it's fine. So I don't know if it's fine or not, but I do know that if you have a patient who recently has had their medications changed, like again, I worked in corrections for years, and people would get admitted to the correctional facility and they couldn't bring in their meds from home. So we would take their meds, put them in their personal property for when they get released, and then we would give them whatever formulary substitution we had. So we weren't giving them identical drugs, we were giving them formulary equivalents. We'd have to watch their levels really closely. What else? There are some warnings about possible suicidal thoughts with anti-epileptic drug use. And yeah, nobody knows why. I've never seen anybody publish a rationale for this. And interestingly, they are at higher risk when the anti-epileptic drugs are being used for epilepsy as opposed to other disorders. As you know, we manage a lot of things with anti-epileptics. Neuropathic pain. In fact, many anti-epileptics are managed more, better with anti-epileptics than anything else. Like we use Topamax for migraine pain. We use Neurontin and Lyrica for neuropathic pain. We use lamotrigine for mood disorders and stuff for bipolar. They're all anti-epileptic drugs, but the risk of suicidality is higher when they're being used for epilepsy, and I don't know why that is. There's another thing to be watchful for, again, carbamazepine. In addition to causing autoinduction of its own metabolism, carbamazepine apparently seems to be a trigger for certain people at high risk for something called toxic epidermal necrolysis. So there is a warning on this drug, especially for persons of Asian descent, because patients with Asian descent are at a higher risk for having a particular antigen. It's this predisposition, genetic predisposition called human leukocyte antigen B1502. And people who have this gene and take carbamazepine are at risk for this very dangerous reaction called TEN, or toxic epidermal necrolysis. Your handout also mentions that it may occur with other anti-epileptics too. We don't usually know if the patient has the antigen or not, so you just have to be on the lookout for it. If you have patients, especially persons of Asian descent, who are started on anti-epileptics, and then they begin to develop ulcerations or skin stuff, this is something to be reported to the resident or the attending immediately. Yeah, this easy for me to say, life-threatening skin disorder. I'm going to show you a picture in a minute, but basically they just erode like from inside out. This is sort of like Steven Johnson syndrome personified. Here you go. So these pictures here, if I remember correctly, this one that is labeled A at the top, where's my little pen? Philly. Wait, I'm going to find a way to highlight this for you. Upper left-hand corner of the screen. You see in the upper left-hand corner of each picture, you see a little letter. Here we go. So here's A, circled in red. Here's B, etc. And you can see C and D. A is not the same person, but B, C, and D are all this same little girl. And this is a little girl who experienced toxic epidermal necrolysis after being given carbamazepine. I guess she was having seizures. And this is what happens. First, it's the rash. A is just here to show you what the dermal exfoliation looks like. But this little girl, I mean, then look, you can see what happened to her skin. She had to be intubated. And then down here at the bottom on picture D is her 2 years later in recovery. But but it is very serious, potentially life-threatening. And again, it's Asian persons are at higher risk because of the higher incidence of this human leukocyte antigen. So you start noticing a funky rash on somebody who's taking a seizure drug, especially carbamazepine, you want to get on the phone immediately. These are just some side effects of antiepileptics. These are reasons people don't want to take it. Facial hair and hirsutism, it can obviously be very distressing for the patient. Gingival hyperplasia, especially some of the older antiepileptics. It's really almost obscene because these teeth look really nice except for the gingival hyperplasia. But this is why some people won't take their seizure drugs. They'd actually rather have seizures once in a while than have to experience these side effects. So one of the reasons we see so many new seizure drugs being developed is that they're trying to find drugs that don't cause this side effect profile. The heck of it is that most of the new seizure drugs turn out to be not as good for seizure as the old stuff, but they do wind up having other utility. Like I said, Neurontin and Lyrica for chronic pain, a lot of them for migraine. Many of them are mood stabilizers, but we just haven't gotten really good at developing good seizure drugs. The older ones do this stuff sometimes. Anyways, that's all I know about seizures, I think. All right, now we're going to switch gears a little bit to Parkinson's disease. Parkinson's disease is a movement disorder, and the bottom line is you don't have enough dopamine. Remember, almost every central nervous system disorder revolves around the neurotransmitter in some way, and in this disorder, it's about not enough functioning dopamine. There's actually a loss of dopamine-containing neurons. So it's a situation where one neuron releases a neurotransmitter to another neuron, which then releases a transmitter to a third neuron, to a fourth, etc. And in the normal circumstance, one of these neurons is a dopamine-releasing neuron. And remember, dopamine is inhibitory. So when dopamine is released from one neuron and it binds to the next, it inhibits excitation in the next. So as long as you have adequate dopamine on board, inhibition of the next neuron is promoted and you don't fire off that next neuron. When you don't have enough dopamine, you don't have enough inhibition. The next neuron in the chain is not inhibited appropriately. It fires off and you just lose your balance. Remember, that one visual you can always keep in your brain about the body is it likes homeostasis. It likes the seesaw to be balanced in the middle. Mess up one side, the other one goes out of whack, and in this circumstance you have Parkinson's disease. So let's try to look at a graphic here. I mean, I don't really mean to obsess over this. What you really need to know at this point is that the problem is not enough dopamine, because virtually all of the different drug classes that we use to manage Parkinson's are about increasing the amount of available dopamine. So let's try to look at the diagram here. All right, I'm drawing a red line vertically in the middle of the diagram. Actually, I'm going to draw a blue line, which will separate this out. See that blue line separates side 1 from side 2 that are now labeled in blue and circled. Okay. 1 and 2 are the same set of 4 neurons. 1 shows it to you in the normal state, 2 shows it to you in the Parkinsonian state. So it's not like these are 8 different neurons. It's a series of 4 neurons, and side 1 shows you what happens when everything is normal, and side 2 shows you what happens when there is Parkinson's disease. And so what happens under normal circumstances is you have neuron, again, I'm going to label this with a little red one. This is neuron number 1, and it's releasing dopamine, and dopamine fires off to the next neuron, which we will label red 2, and dopamine inhibits it. That's why we have this little minus sign up here. Dopamine is inhibitory. So when dopamine fires from neuron 1 to neuron 2, it inhibits it. Now that neuron would have released acetylcholine, except that the dopamine inhibited it from doing so. Okay? If it released acetylcholine, it would fire off acetylcholine to neuron 3. Now acetylcholine is excitatory. So again, if there wasn't enough dopamine to inhibit the acetylcholine, acetylcholine would be released and it would fire off to neuron 3, which is a GABA-producing neuron. And then GABA would fire off to neuron number 4. Now GABA is inhibitory, so If GABA fired off from number 3 to number 4, it would inhibit number 4, and number 4 would not fire off. And number 4 fires off out of this functional area of the brain to affect motor function in the rest of the body. So taking it from the top here, in the normal patient, which is number 1, we've got a relationship among 4 neurons. A dopamine neuron, an acetylcholine neuron, a GABA neuron, and a GABA neuron. Remember that dopamine and GABA are inhibitory, acetylcholine is excitatory. So in the normal patient, as labeled number 1, they release dopamine. Dopamine inhibits acetylcholine, so acetylcholine is not released. That's why I'm now drawing a red X over this arrow where acetylcholine would be released to neuron 3. Again, dopamine is released from neuron 1 in the healthy patient. Neuron 1 releases dopamine, which inhibits neuron 2. Neuron 2 does not excite neuron 3. Then neuron 3 does not release GABA. So GABA does not fire to neuron 4. Neuron 4 is not inhibited. GABA is then released out into the general circulation. So some inhibition is going on from this GABA, and it's inhibition of skeletal muscle contraction. Muscles don't contract as much. I'm going to say it one more time. In the normal patient, they release dopamine from number 1. And dopamine inhibits number 2, which is acetylcholine. So acetylcholine is not released. So it does not excite neuron 3, which means neuron 3 does not release GABA. So GABA does not inhibit neuron 4. Neuron 4 releases GABA out into circulation and inhibits skeletal muscle contraction, so you have skeletal muscle relaxation. Now, in Parkinson's disease, which is number 2, look at what's going on. In Parkinson's disease, you have a dashed line here between dopamine and the acetylcholine-producing neuron. The dashed line means there's not enough dopamine. There's a loss of acetylcholine-producing neurons. So now, if you don't have enough dopamine, see where I put the red X? If you don't have enough dopamine, you don't inhibit acetylcholine. If you do not inhibit acetylcholine, it fires off to neuron 3 and excites it. And when neuron 3 is excited, it releases GABA to neuron 4. And when neuron 4 gets excited, it releases GABA to the general circulation, which is inhibitory. So see how the balance of inhibition and excitation is lost. Again, in the normal patient, number 1, you have enough dopamine. Dopamine inhibits acetylcholine. Acetylcholine is not released. It does not excite number 3 GABA. If you don't excite number 3 GABA is not released. You don't inhibit number 4. Number 4 releases GABA into general circulation, and you have some inhibition of skeletal muscle contraction, which is as it should be. In the second scenario, side 2 of this graphic, you don't have enough dopamine producing neurons, so you do not have inhibition of neuron 2. If neuron 2 is not inhibited, it fires acetylcholine to neuron 3. If neuron 3 is excited by acetylcholine, it releases GABA to neuron 4. If GABA is released to neuron 4, it inhibits neuron 4 from releasing GABA into the general circulation, and now you do not have inhibition of skeletal muscle contraction, and now the muscles contract inappropriately. And what you've got is stiff, stooped gait, wooden facies, cogwheel rigidity, and all of the other manifestations of too much contraction. That's what's happening in Parkinson's disease, and it all comes back to not enough dopamine. So every drug therapy has something to do with dopamine. The first one is Sinemet. You know it is Sinemet. This is levodopa, carbidopa together. Levodopa is the precursor of dopamine. If you give somebody levodopa, it will break down in blood to dopamine. We give it in the form of levodopa because levodopa can cross the blood-brain barrier. Just giving dopamine can't. If you're an ICU nurse, you have probably administered dopamine. You know, we give dopamine to people for blood pressure, maintenance, you know, when they're like symptomatically hypotensive and shock or whatever. But Dopamine doesn't cross the blood-brain barrier. Levodopa does. Levodopa then crosses the blood-brain barrier, will be metabolized into dopamine. And then carbidopa, the other aspect of this medicine, just blocks its breakdown. It slows down the metabolism. So now you're giving people a dopamine precursor. It crosses the blood-brain barrier, hangs out in the brain, and doesn't break down as quickly because of the carbidopa. That's what Sinemet is. It is replacing dopamine that's missing. So that's what it does. It replaces dopamine. So the side effects of it are the side effects of dopamine, which is an amine, and dopamine will raise blood pressure. It changes the normal compensatory mechanisms of vasoconstriction so that you don't appropriately compensate for changes in position. There is the potential for orthostatic hypotension, but more likely tachycardia and palpitations, and just, central nervous system activation. Those are the side effects. Now, if the patient is dosed appropriately, they don't usually feel this a whole lot, but you certainly can see like a rise in baseline pulse from like 70 to 90. It's not prohibitive of using it. It doesn't mean you're going to DC the drug, but it will cause an elevation in pulse and maybe the sense of palpitations in the patient. But that's what it is. It's dopamine. Sinemet is just replacing dopamine. It is kind of the gold standard. Most people, well, everybody with Parkinson's disease will be on Sinemet at some point. Lots of providers start them out that way. Others try to hold off a little bit for reasons that we'll talk about next. Other side effects, again, same side effects of dopamine, flushing because of this central nervous system activation, anorexia, nausea, and vomiting, again, because of shutting down of the gut, like sympathetic nervous system activation activates fear, flight, fight, and suppresses those vagal responses like digestion, urination, stooling, stuff like that. The on-off phenomena is what happens when the body begins to adapt to this synthetic dopamine. What will happen is patients have symptom control for a few hours after taking it, but shortly before the next dose, the Sinemet starts to wear off, and you see a marked recurrence of symptoms, and it's called the on-off phenomenon. Most of you probably won't remember this, but many, many years ago, Michael J. Fox, is a popular actor in the 80s and even 90s, I guess. And he developed Parkinson's disease really young. And years ago, he testified in front of Congress, I think, like trying to advocate for stem cell research for Parkinson's disease, but like purposefully didn't take his meds. And his symptoms were just, really, really dramatic. And then as soon as he took his meds, there was appreciable control. This is the on-off phenomenon. Another class of drug that we use to manage Parkinson's disease are dopamine receptor agonists. These are dopamine mimetics. These are like fake dopamine. Sinemet is real dopamine. Levodopa breaks down into dopamine. These dopamine receptor agonists aren't actual dopamine. They're a compound that acts like dopamine, and they act like dopamine in that functional area of the brain. So you may know some of these names, Requip and Mirapex especially. These are used now more for restless leg syndrome, I think, than anything else, but these were originally designed as dopamine receptor agonists. That's what they do, and they can mimic the effects of dopamine in people that are have developed symptoms of Parkinson's disease. So there's pros and cons to using these instead of Sinemet, instead of using them first. But the difference is Sinemet is actual dopamine. Dopamine receptor agonists are fake dopamine. So the mechanism of action of fake dopamine is it stimulates dopamine receptors in the basal ganglia, which is the functional area where Parkinsonism is a problem. They are most useful earlier in the disease when the patient first begins to become dopamine depleted or dopamine deficient. That's when these are best. And the real upside is that they may delay the need to begin Sinemet replacement. The thing about Sinemet is it has like a life expectancy in almost every patient. And that life expectancy, and I don't mean the patient's life, I mean the life expectancy of the drug, of how long the drug will be useful, is somewhere around 5 years, give or take a year or two. A Sinemet will work for about 5 years before I really don't know what happens if the patient just becomes tolerant or what. But there is a distinct finite lifespan of the utility of this drug. So if you start it early in disease, then you're going to get symptom control for give or take 5 years. If you can start it later, if you can put off starting Sinemet, then overall you get like a longer treatment course. So some providers will use dopamine agonists first. You can get symptom control with dopamine agonist, especially in younger patients. You can get symptom control sometimes for a number of years. And then when this doesn't work anymore or they become tolerant of it, you add the Sinemet. And then the Sinemet gives you another 5 years. So the greatest utility here is that they may delay the need to begin dopamine replacement. The downside is because this is a fake version of the neurotransmitter, it's just not as precise as the real thing, and the side effect profile is more pronounced. So all those side effects that I mentioned that were potential with Sinemet, they're usually more pronounced in people that take dopamine agonists, which is why they're really more appropriate for younger people. So all of these side effects, I just made a new name. All of these side effects are similar to the side effects of Sinemet. That's where, I don't even remember what I just said. Anyway, these are the same side effects that you may see with Sinemet, but they tend to be more pronounced. All symptoms of a dopamine excess, dopamine activation. I better just get off this slide before I trip over my own words again. Here you go. Yeah, when I say younger, I mean under 70. They are considered among first-line therapy in patients under 70. Now, you watch 5 neurologists treat Parkinson's disease, and you'll see it 5 different ways. I mean, there's a lot of individual decision making, but as a general guideline, these are considered appropriate as first-line therapy in people who are under 70 at the time of symptom onset, and they can delay the need for Sinemet for up to 5 years. So if you don't start the Sinemet until 5 years later, you get a total of at least 10 years of symptom control, and that's awesome. When patients become intolerant of these dopamine agonists, then you start adding low doses of levodopa as needed. Another class of drug, and this is the only one that doesn't directly impact dopamine in some way, are the anticholinergics. Now remember when we looked through that parade of neurotransmitters, what I said was that in Parkinson's disease, you don't have enough dopamine. So if there's not enough dopamine, you can't inhibit acetylcholine, and acetylcholine is then released unbalanced, unchecked. In other words, too much acetylcholine. Not enough dopamine means too much acetylcholine. One way to control the symptoms of too much acetylcholine is to give anticholinergics and block the action of acetylcholine. And that, I mean, this is an old-time drug for Parkinson's disease. And what's the name of that drug? I can't believe I can't think of it. An old-time anticholinergic for Parkinson's disease. Oh, I'm sure it will come to me later. It works. It works to help reduce the symptoms, but the downside is the anticholinergic. Excuse me. I didn't have time to hit pause. Sorry. The downside is the anticholinergic side effects, the constipation, the urinary retention, the dry mouth, etc. I actually have a patient right now who, and again, I practice in a very rural environment, so I tend to see people that don't want to go to specialists or don't have access to specialists. And a long time ago, this man was put on Sinemet and an anticholinergic for his Parkinson's disease. And the anticholinergic is giving him significant constipation, but his symptom control is so amazing. And he was starting to ask about, can we change this because I don't like that it makes me constipated. And I said, Parkinson's is just it can be such a challenge to manage, and yours is managed so well. Why don't we try doing something about the constipation? Put him on a little Miralax. Now he's going to the bathroom every day, and everything is awesome. So the anticholinergics, they are effective. They're usually not the go-to drug first, but they are effective. It's just those anticholinergic side effects. They're a problem for everybody. Another option, switching gears a little bit, are the catechol-O methyltransferase inhibitors, or COMT inhibitors. There's a couple of them on the market. They're listed here on your slide. There's Comtan and Tasmar. If you see people that are on these for Parkinson's disease, these are pretty heavy duty. COMT is a naturally occurring enzyme that breaks down dopamine. Remember what we said about neurotransmitters in the very beginning of this lecture, is that neurotransmitter is released from a neuron, from a nerve terminal, and then it diffuses across the synaptic cleft and binds to a receptor on the other neuron. And then that neurotransmitter is either reuptaken, it is enzymatically degraded, or it just diffuses away. Well, in the case of dopamine, it is enzymatically degraded by a few different enzymes, and one of them is COMT. So COMT breaks down dopamine very quickly. So we then can give this medication that blocks the action of COMT, which blocks the breakdown of dopamine, so dopamine just gets to hang around longer and hopefully do its job. So that would be a good thing. Notice that they should be used with dopamine. These should be administered to patients who are already on dopamine, because these are later in the progression of disease. These aren't like a first go-to medication. These get added on to dopamine, especially when the dopamine begins to, when you start to have that on-off phenomenon, when the dopamine's just not lasting as long, COMT inhibitors may be added. These are heavy duty. These are kind of a last-ditch effort in patients who are not responding to other drugs, and they can be extremely liver toxic. Look at the liver function monitoring. LFTs every 2 weeks for the first year of therapy, then every 4 weeks for 6 months, and then every 8 weeks into infinity. And these are not supposed to be maintained if they don't cause significant improvement in the patient. So again, the implication for us is that when you see these people, whether they're your hospital patients or they're your outpatients, if they're on medications like Comtan and Tasmar, you know that their liver function tests are extremely important. They need to be followed up with. A lot of people, they will have drugs started by a specialist, or they'll have drugs started in the hospital, and they get told what they have to do, and they nod their head yes, and then they go home with all their discharge papers or all their instructions from the specialist, having no idea what anybody said, and then they don't follow up on it. And part of our job is to help with that transition and help make sure that they really do know what to follow up on, and getting their liver function test if they're on COMT inhibitors are among them. Now, a slightly different take on this dopamine breakdown theme is the MAO-B inhibitors. MAO-B is monoamine oxidase, and B is one form of it. There's also MAO-A. But MAO-B inhibitor, or MAO-B, is another enzyme that breaks down dopamine. So we do have another class of drug, the MAO-B inhibitors, that help block the breakdown of dopamine by this mechanism and increase the amount of dopamine that's at the synapse. So this old-time drug Eldepril, this is selegiline, and selegiline has been used in Parkinson's disease for a long time. It's not nearly as toxic as the COMT inhibitors, and for that reason, not as effective either. But this, it's a safer drug. It's usually more of a go-to drug earlier on. It should also be given with Sinemet. And that's what it does. It ultimately increases the amount of dopamine available. So like every other drug that increases functional dopamine, Sinemet, dopamine agonists, the COMT inhibitors, and the MAO-B inhibitors, they can do the same thing. They increase symptoms of dopamine, cardiac activation, dysrhythmia, palpitations, hypertension. Now, too much dopamine in the brain can even make you psychotic. In fact, that's one of the problems in schizophrenia, is there is too much active dopamine in certain functional areas. So there's a real fine line between enough dopamine to replace what's missing or too much dopamine to cause psychotic symptoms. So if you have patients that are new or having drug dose changes for these drugs for Parkinson's, do be on the lookout for what appears to be psychotic symptoms. It happens, and then the doses have to be backed up with. Should not be used with heterocyclic antidepressants, because heterocyclic antidepressants also increase the amount of amines in the brain. That's Seesaw. You need to have just enough dopamine to keep your muscles moving the right way, but not too much to make you psychotic. Nobody said it would be easy, you know? It's a hard job we do. All right, last couple of things worth talking about here, Alzheimer's disease. The neurotransmitter of interest in Alzheimer's is acetylcholine. Let's see. So the pathophysiology of Alzheimer's, and this is like a really well-published, almost everybody seems to know the pathophysiology of Alzheimer's. You have this plaque accumulation in numerous areas of the brain and loss of neurons in the part of the limbic pathway that drives memory. So as disease progresses, you will lose more and more neurons, but some of the earliest findings are believed to be those that contribute to short-term memory loss, and that is the loss of acetylcholine neurons in the limbic system. So the rationale for the treatments that we have for Alzheimer's disease is that we are trying to increase the amount of functional acetylcholine at those synapses in the limbic system. Treatment for Alzheimer's disease, and mind you, this isn't treatment to cure the disease. I mean, you can't cure Alzheimer's or even slow the progression. All we can do is try to improve the amount of acetylcholine in these functional areas so that we can improve memory. So treatment centers around increasing available acetylcholine, which has more acetylcholine at the receptor site. So the relationship of these neurons in the limbic pathway is that you've got a presynaptic neuron that releases neurotransmitter, and then a postsynaptic neuron, which is what the transmitter binds to. Acetylcholine is released from the presynaptic neuron. Some of it binds to the postsynaptic receptor and carries the message of memory forward in the limbic system. And then that neurotransmitter acetylcholine is very quickly broken down by the enzyme acetylcholinesterase. I'm sure we've said this before, but remember, when you put ACE on the end of a word, it breaks down the first part of the word, right? Lipases break down lipids, proteinases break down proteins, amylase breaks down amylin, and acetylcholinesterase breaks down acetylcholine. So the normal chain of events is you've got two neurons communicating memory in the limbic system. The presynaptic neuron releases acetylcholine, and the message of memory is carried via acetylcholine to the postsynaptic neuron. Acetylcholine binds to it, carries the message, and then is immediately enzymatically degraded. We don't like to have lots of acetylcholine floating around the body because it just does all those things that acetylcholine does. We don't want it happening too much. Remember, acetylcholine is the primary neurotransmitter of the parasympathetic nervous system. So if you have too much acetylcholine laying around, you're going to be like all stimulating your bowel and having hyperperistalsis and abdominal pain and diarrhea and vomiting and urinary incontinence and bradycardia and salivating all the time, all those things that acetylcholine does, right? So we just want acetylcholine to be bursted into the brain, carry the message of memory, and then acetylcholinesterase immediately breaks it down. That's the way it's supposed to be. Acetylcholinesterase inhibitors are medications that block the action of acetylcholinesterase, thereby increasing the amount of acetylcholine available at the neuron for binding, and it increases acetylcholine, which is great in terms of memory and Alzheimer's disease. The downside is you will increase the amount of acetylcholine in the rest of the body, and that's what creates your side effect profile. But if you're having a memory issue with Alzheimer's, it's a good thing to have more acetylcholine in your brain. As long as the side effects aren't prohibitive and your memory improves, everything is awesome. So there's a few different drugs in this class. I'm sure you're familiar with some of them. Aricept is probably the most famous, and Aricept has some good features and some bad features. A good feature is not hepatotoxic, so it's very safe from a liver perspective. The downside, it is a cytochrome P450 substrate. It's metabolized by one of the cytochrome P450 family, so you do have to be on the lookout for drug interactions, which is always a risk in the older population, because I think the statistic is something like your average older adult is on 6 prescription medications and 2 over-the-counters. So, safe on the liver, not so good with other drugs. So that's one thing to consider. Another thing, your slide doesn't say it, but these can be taken once a day. And in Alzheimer's disease, that's huge, because remember, with Alzheimer's, the big problem is you have memory issues. So remembering to take something once a day is usually, as good as you can push it. I remember the very first drug in this class that was released for Alzheimer's disease. This was years ago, and it didn't last very long. Its brand name was Cognex. That drug had to be taken 4 times a day. I mean, it was almost perverted in its, in the paradox that, who with Alzheimer's disease is going to remember to take a drug 4 times a day? Anyway, that's what Aricept is. Once a day, it is metabolized by cytochrome P450. That's its biggest downside. On the other hand, we have Exelon. Exelon has a different profile. It has to be taken with food, which adds something to the memory, although Alzheimer's patients are really responsive to routine. Alzheimer's patients do extremely well with routine. So if you begin the routine of taking it with a meal, then that usually isn't too hard to navigate. This is not metabolized by cytochrome P450, so it's a better choice in people who are on polypharmacy. Your slide doesn't say it, but this one has to be taken twice a day. So it is a little bit more of habit setting, but if the patient is having breakfast and having dinner, then that's usually the time to do it. The primary adverse effects, like I said, these are drugs that increase the amount of acetylcholine in the body. So in the brain, that's a good thing. In the rest of the body, it's not. Primary side effect profile with these is GI. Patients really do complain of abdominal discomfort, diarrhea. Some of them even complain of nausea because they're hyperperistalsis. And sometimes the patients will get bradycardic. And they don't come in and say, oh, hello, I think I'm having an acetylcholine-mediated side effect of my Aricept. They don't say that. They just say things like, gosh, I'm just so tired. I'm never tired like this. I usually have a lot of energy. And you check their pulse and it's 42. And it's because of the Aricept. That really does happen like some degree of the time. So be watchful for these acetylcholine-mediated side effects. And you want to tell the patients if they get started on this, and lots of people get started on this in the hospital too. And there's usually so much else going on, you just don't know what to attribute side effects to. But you want them to know when they go home. If they're feeling really tired all the time, if they're capable of learning how to take their pulse and can understand the implications, you can teach them that. Let them know that if they're having vomiting or, diarrhea, that things have changed in their gut, that they definitely need to let their primary care know. And let them know that they just started taking one of these medications. But for patients that truly have Alzheimer's, they can make a difference in memory. Now, other forms of dementia don't have this pathophysiology, so other forms of dementia won't respond to these meds as well. Most of the time when you hear people say that they tried these Alzheimer's medicines and they didn't do any good, they don't really have Alzheimer's to begin with. They had some other form of dementia that has nothing to do with acetylcholine. These drugs only work in people who have an acetylcholine deficiency in the limbic system. Now, another class of drug, the only other class of drug we have for Alzheimer's, are the NMDA receptor antagonists. That's N-methyl-D-aspartate. These work on that presynaptic neuron. Remember the relationship again. A presynaptic neuron releases acetylcholine to a postsynaptic neuron, and then acetylcholinesterase breaks it down. The last group of drugs we were talking about were acetylcholinesterase inhibitors. This drug, and there's only one in class, it's called Namenda. Namenda is a medication that blocks one of the stimulus of the presynaptic neuron to be broken down. Like, there's this theory that one of the problems with Alzheimer's is that the presynaptic neuron, the one that releases acetylcholine, has become overly excited and then basically explodes. It just sort of shrivels up and dies. It got overexcited. And the reason people think it got overexcited is that the excitatory neurotransmitter glutamate turned it on. So if we give an NMDA receptor antagonist, we can block glutamate from overexciting that presynaptic neuron. It won't explode and die, and then there'll be more neurons to release acetylcholine. So this works sort of complementary to the acetylcholinesterase inhibitors. This drug helps preserve the neuron that releases acetylcholine, and then drugs like Aricept block the breakdown of acetylcholine once it's released. So you can see why giving them together is a good thing, and it's actually the standard of care now to give Namenda and a cholinesterase inhibitor together. There is a drug on the market. It got approved like 2 years ago, I think. Let me see if I can find the name of it while I'm sitting here talking to you, and not waste your time doing so. It's a combination of Aricept and Namenda, combination agent for Alzheimer's disease, and it is called, oh, that was so anticlimactic. I thought I would have the name by the time I said that. Combination therapy in Alzheimer's disease. Oh, wait, I should have put combination drug. Namzaric, that's the name of it. It's called Namzaric, Namzaric, and it is a single pill that has both Namenda and Aricept in it because it helps preserve these neurons from 2 different directions. Of course, you thus really do increase the amount of acetylcholine available, so do watch those side effects. They're really not at all unusual in people who take them. And the bradycardia and even the vomiting and nausea can be prohibitive, and diarrhea. All right, last thing worth talking about is anxiety. So the problem with anxiety, again, here we go, precise mechanism is unknown, but it is theorized to be heightened excitability in a particular area of the central nervous system. Makes sense, right? In anxiety, everything's a little bit kind of overdrive. So in the brain, it's all about excitation and inhibition. And with anxiety, it is believed that there is too much excitation. So treatment of anxiety centers on promoting inhibition, blocking excitation or promoting inhibition. So the area of anxiety is believed to be around the area of the pons, which is very close to the area for depression. I mean, mood is mood, right? And here we are. I just drew a red circle around it. The area of the pons, that's believed to be the functional center for anxiety, very close to the functional area for mood. So it's not a surprise that it's the same drugs often that are used to treat anxiety disorders. The SSRIs, we talked about these for depression, so I'm definitely not going to beat up, that dead horse again. Same drugs are indicated for many anxiety disorders, and so all the information about them is the same. The only difference is that usually for anxiety you need a little bit higher doses. Same thing, the SNRIs, the atypicals, and even the tricyclics have also been demonstrated to be very useful in anxiety. It's just that, again, the heterocyclics don't get used as much just because of the potentially dangerous side effect profile, but they are useful. Almost all the drugs that are used for depression have utility in chronic anxiety diseases. Now, the one class of drug we haven't talked about for anxiety are the benzodiazepines, because these are pretty specific to anxiety and, of course, also used in some cases to suppress seizure, because these are distinctly inhibitory. Benzodiazepines are first line for acute symptom management. Acute anxiety, panic attack kind of stuff, these are suppressive. They bind to a very specific GABA site. Remember, GABA is the most common inhibitory neurotransmitter in the brain, and if you want to calm things down, give a drug that acts like GABA, and that is the benzodiazepine. There's a bunch of them out here, and they're all they all have their little tweaks. Xanax, I'm sure you're familiar with. This is most useful for panic. Xanax was never intended to be used every day as a chronic anxiety tool. None of these were really intended to be used every day. With one exception, and we'll get there in a minute. Xanax is very appropriate for I have to get on a plane and I'm scared to death, or I'm having a big operation tomorrow and I'm so scared I can't sleep. Very appropriate for that. It's just been so misused that now it has a bad name. Valium is a little bit longer acting, and that has been used for generalized anxiety, but again, we have safer drugs now. It's never meant to be anybody's first line tool. Librium is probably most widely used for alcohol withdrawal, because alcohol withdrawal is acute central nervous system excitation. I mean, remember, alcohol is a central nervous system depressant. And when you depress the central nervous system long term, like in alcoholism, and then suddenly stop drinking, it's like you're putting your central nervous system into overdrive. In fact, benzodiazepines are often considered a pill form of alcohol. So when patients are going to acutely detox from alcohol, we give them a lower and tapering dose of Librium or any benzo just to try to help wean them off the alcohol. Ativan is very much like Valium, a longer-acting benzodiazepine. Again, not meant for long-term use. We use these as much for seizure suppression as anything else. Restoril is a benzodiazepine that is used as a sleeper, and even as a sleeper, it's not meant to be used every night for the rest of your life. It's meant to be used on times when sleep is especially difficult and the patient needs some help. Klonopin was the one that's designed for maintenance. This was years ago designed as a chronic seizure drug, and now, of course, we just have others that are better, so it doesn't get used. But Klonopin is frequently used in people that have been on benzodiazepines for the very long haul. It's really hard to get them off it. So instead of having them on something like Xanax that they have to take 4 times a day, they get switched to Klonopin as a maintenance dose once or twice a day. Klonopin is also useful, like longer term, for alcohol withdrawal. And Klonopin, oddly enough, like some of these drugs do have skeletal muscle relaxant properties, and Klonopin is particularly useful for people that get like somatic muscle pain, you know, like that really, really intense muscle pain in their neck or upper back or something. Klonopin will usually help that. Sirax has its own distinct little place in the world in that it's especially safe in people with liver disease. So, you know, a lot of people with like later stage cirrhosis or, you know, in the hospital, like dying of liver failure, of course they're anxious. And Sirax is a particularly safe one in that it doesn't exacerbate liver problems. Some benzos reduce anxiety at doses that do not produce sedation, and that's true. I mean, some benzos, we use them to sedate people, like Restoril. We want that to be a sedative hypnotic. Others, like Ativan, we don't necessarily want the patient knocked out. We just want their anxiety relieved. And then most benzos are metabolized by the liver to active metabolites, so they can hang around for a long time. Again, it's the Sirax that can't. So that's why we like Sirax in liver disease. And then finally, I think this is the last slide. Just a reminder that benzodiazepine withdrawal can be very dangerous. It's one of the most dangerous withdrawals because it is directly suppressing the central nervous system. If the patient's been taking it for any length of time, they have been pharmacologically suppressing their central nervous system. If you suddenly stop taking this drug, your central nervous system goes into overdrive. I've seen patients die from benzo withdrawal, and they haven't even been taking it all that long. Most withdrawals, the patient will survive them just fine. They don't feel good. You know, they might be puking and all that kind of stuff or in pain or whatever, but they don't die. But benzo withdrawal, like alcohol withdrawal, is one of those withdrawals you can die from. So if you're admitting a patient who is in benzo withdrawal, make sure that whoever is doing, you know, the admitting orders knows that, because these people, like, they need to be put on something. They need to be put on a slow, steady taper. In the outpatient world, when we're trying to get people off of benzodiazepine, we reduce it by like 0.5 milligrams a month. So if somebody's taking, you know, 2 milligrams of Xanax 4 times a day, they're taking 8 milligrams of Xanax a day, 0.5 milligrams a month. So it's going to take 16 months to get them off it, but at least it will happen safely. So that's all I know. Hope it was helpful, and I'll see you next week.